A very warm welcome to everybody joining us today for another Observatory webinar. This webinar is going to launch a new policy brief produced by the European Observatory and funded by the Health Foundation, which focuses on provider competition. My name is Ewout van Ginneken of the European Observatory in Health System Policies, and I will be moderating this webinar together with my colleague Erica Richardson, from whom you will hear in a minute. Provider competition is a feature of several European health systems, but policymakers are quite split on whether it improves healthcare quality and efficiency. And especially now that many systems are moving towards integrated care, there are many questions to be asked. In this webinar, we will be focusing on some of them. We will, for example, talk about, does hospital competition improve healthcare quality? Do patients choose based on hospital or primary care provider quality? What does the evidence show us? And also, does competition get in the way of integration? We will try to answer these questions with a very excellent panel of speakers with not just one, not two, but actually three professors of economics. And the first speaker to give the keynote presentation will be Luigi Siciliani. And Luigi is a professor of health economics at the Department of Economics and Related Studies at the University of York. And he was the first author of the brief. His research focuses on the economics of hospitals, waiting times, hospital quality competition, contracts, pay for performance, and much, much more. You may have seen him earlier this year in a webinar on measuring backlogs in care, and also in a webinar on market reforms in the Dutch system. After Luigi, we will have two spotlight presentations. The first spotlight presentation will be from Karine Milsan from France. Karine is a research director at the French National Center for Scientific Research. She's also an associate professor at the Paris School of Economics, and her main research includes economic evaluation of health systems, inequalities in access to care, and the regulation and financing of healthcare systems. And as a second perspective, we will hear from Finland, from Mika Kortelainen, and Mika is a professor of health economics at the University of Turku. His research covers competition in healthcare, effects of the healthcare and pharmaceutical market reforms, and healthcare financing and healthcare information technologies. But before we go to Luigi, we want to go to Erica to launch a poll. Erica.
Hello, everyone, and welcome to this webinar. Lucy, could you put the poll up on the screen? So just a quick audience poll just to see where we are, because we'd be really interested to see what you feel about this topic. So the first question is, do you think increased competition between providers is beneficial to the health system? And that's just a straightforward yes, no question. And if it's yes, where might these benefits be seen? And you can answer for more than one thing. So might it improve the quality of care, increase patient choice, improve efficiency, something else, none of the above? But it'd be really interesting to see your thoughts on this. Thank you very much. Back to you.
Thank you very much, Erica. Then we can go to our keynote. Luigi, the floor is yours. And the result of the poll will come after Luigi's presentation.
Thanks a lot for the opportunity to present the policy brief on the provider competition. So I'm going to start by just discussing what does actually provider competition mean. And the point I want to make is that provider competition is a multidimensional concept, and different people think about different concepts when they try to relate to competition. So the first possible meaning of provider competition is related to patient choice. So if you think about competition, you may think, well, as a patient, if I can choose where I want to go, that sounds like a competition related policy. And that also links to public reporting, facilitating this patient choice by giving patients good quality indicators. So that's one dimension of competition, which is more on the demand side. The second dimension of competition, which is more like on the supply side, is whether if you are like a provider, a hospital or a GP, is it the case that if you have lots of other providers around you, are you going to make more effort to either keep costs down or to improve the quality of care? Most of the focus here is on quality competition, because most of the times the tariffs and the prices are fixed and regulated. So for hospital, we have activity-based financing in many countries. GPs, they either have fee-for-service system or capitation. But some countries like the Netherlands, they also have some elements of price competition. So when the hospitals has to negotiate on price, so that's a different dimension of provider competition, more on the supply side. So that's the second possible dimension of competition. A third dimension that I want to mention is private providers. For some people, competition just means more involvement of private providers, and the argument is that they will bring more efficiency to the health system and so on. So I want to that's quite a distinct and separate dimension of competition. For some countries, it means more use of the markets by involvement of private providers. Last, you could also have some policy interventions that imply less competition. So here I have two examples. One is mergers or hospital mergers, for example. We have mergers all the time, and you could interpret this as a situation where patient choice is actually restricted if two hospitals merge. And maybe you could think similarly about the recent policies on integrated care, maybe for chronic conditions or more generally. Whenever you mention the word integrated care, that sounds like a consolidation of providers, and that potentially could also lead to a restricted patient choice and less competition. So I want to discuss what I want to do next is for each of these items to discuss what is the evidence that we have on each of these different dimensions of competition, and what sort of implications can we draw for each of them. Okay, let's start with patient choice. Here we have quite a few studies across European countries. We have studies for England, the Netherlands, Germany, Norway, Italy. So we have like a good evidence base. And these studies actually, they say mostly the same thing, which is patients, they go local. So they go to the local provider. They dislike to travel. So that their closest provider is the most likely provider that they're going to go to. Now, quality differences also matter, but the effect is relatively small. So it is true that if there is like a significant gap between on quality between two providers, that provider who has higher quality will have more patients, but the effect is relatively small. What we still don't know from this evidence is exactly who is making these choices. Is it actually the patient themselves who are doing the choice, or is this channeled through their GP, for example? So is it that the GP that is choosing on behalf of patient? We also have quite a lot of evidence on hospital choice, but we have less evidence on how much patients exercise choice for primary care doctors, and that's mostly due to data limitations. So what sort of implications or policy implications can you draw from this evidence? Well, that depends a bit on your starting point. So if you are someone who is kind of against competition, you could say, well, this evidence suggests that patient choice doesn't really work. On the other hand, if you are in favor of competition, you could use the same evidence to argue that we have a decent base where patients are making choice based on quality. So what we can do is to improve to develop the patient choice by improving public reporting, developing good indicators. And there is quite a lot to be done in terms of making sure that these quality indicators that are in the public domain are reported in an accessible way. Okay, so that's patient choice. The second dimension of competition that I have mentioned is whether is it the case that if you are like a hospital and you face lots of rival hospitals around you, are you going to provide higher quality? So what does the evidence say about that? Again, here we are like in a reasonably good position in terms of the evidence. We have, again, studies from England, France, Norway, Netherlands, and Italy. So this literature has been growing, this empirical literature has been growing. And what does this evidence say? Well, this evidence says that either you find some positive effects, often in terms of reduced mortality rates, or no effects for other indicators. So you often find this indicator on heart attack mortality, which is always lower in more competitive areas. But then you don't find the same effect for other mortality indicators. For example, if you look at stroke mortality, then most often you find like a zero effect. And occasionally you do also find some negative effects, though in my reading, these negative effects are in their magnitude are smaller relative to the positive ones. So the evidence is mixed, and what we still don't know is the mechanism at work. We know a little bit about the mechanism, that possibly we have identified the management of the hospital as a key factor, which is intuitive, but we still don't know exactly when things go wrong and competition does not have an effect on quality, or maybe has a negative effect on quality, what is that is exactly going on. What we do know in terms of policy implications is that when you do have the positive effects on quality, that's more likely to happen when the tariffs and the prices are fixed for the provider. If you do have that the hospitals or the providers are negotiating on prices as well, that potentially could push down quality. Because if you have more competitive areas, prices go down, but that can push down quality. Another implications that I want to draw out is in terms of this perceived tension that you have between competition or activity-based payments and expenditure control. So that came out from a few of the examples, is that to have a competition between providers, you need to have like an activity-based payment. But if that leads to high volumes, that can be in conflict with high spending. So one solution that has been brought forward to address that is to introduce mixed or blended payments, but that is in conflict with the competition idea, because if you're bringing the tariffs down to, let's say, 50% of the cost, well, then the incentive for providers to compete according to the policy making mechanism is not going to work anymore, because the tariff is just too low. Okay, so that's the second dimension of competition, is the provider competition as you respond to other providers. The third dimension I want to discuss is private providers, because again, sometimes that's what people think. Competition just means involvement of more private providers. So what does the evidence say about the differences between public and private providers? Is it the case that they are better than public provider? Well, again, we have quite a lot of studies that tries to compare these two types of providers. We have studies from England, France, Germany, Norway, and Italy. And what this evidence says is that the two types of providers, they do not systematically differ. By that, I mean that sometimes you find quite a lot of zeros. There is like no difference between the two. You can find some positive effect in favor of the private providers, but you can also find some negative effects, so that the private providers are not necessarily doing better. Another thing that one result that I find quite interesting from the evidence is that public and private providers seem to differ less when they are paid in the same way, which sounds quite intuitive. But in the past, you had some institutional setups where private providers were paid fee for service, the public providers were paid by fixed budgets, and therefore, their behavior might differ just because the payment is different. But many systems have evolved towards an equalizing payment mechanism where you have like the same activity-based fundings for them. And when that happens, then the two types of providers that do not differ so much anymore. From a methodological point of view, another point I want to make is that it's quite important in these empirical studies to control for patient case mix. And that's because private providers tend to treat less complex patients. So if you're trying to compare readmission rates and mortality rates between the two types of providers, you could infer that the private providers have better quality because you observe lower readmissions, but that could just reflect case mix. Okay, so that's what the evidence says. In terms of the policy implications, if you find that the two types of provider do not differ, what does that mean? Well, we do observe that countries differ in the way they organize in their public-private mix. Now, if you have the Netherlands where you have only non-profit private providers, some other countries rely more on public providers. So you can rely on private provision to expand the capacity quickly. If that's, if, for example, if you have a backlog and you want to expand capacity quickly, that could be a policy option, but that does raise issues. For example, if you think about the health workforce, both the private provider and the public provider are recruiting doctors and nurses from the same market. There are issues that needs to be sorted around here. Also, if you're going to use both public and private providers, what are you going to do in terms of payment? Are you going to use like a differential tariff, perhaps to reflect the lower case mix of private providers, or are you going to pay them the same? So you can see that this competition elements on private providers, once you look at the details, raises all sorts of institutional details and quite a lot of policy choices that have to be made. Okay, let me now move to my last 2 points about some negative forms of quality. So if you have hospital mergers, for example, you could worry that this can reduce patient choice and reduce competitions across providers. So hospital mergers, we observe them all the time, and this is probably driven by the secular reduction in length of stay. So there is like a good reason why hospitals may want to merge and try to exploit more scale economies if they are investing in new machines and more expensive machine. But there is that concern that access may be reduced as a result of that, or patient choice may be restricted. Now, when hospitals are merging, what they often claim is that quality is going to improve. I mean, that's the case that often they make against the antitrust authorities, is that actually, as a result of the merger, quality will go up. Now, that's where the evidence can contribute to clarify some of the issues. I think we have, unfortunately, only very limited evidence for European countries. We have quite a lot of evidence from the US, though it might be more difficult to translate that into the European context. But basically what this evidence suggests is that when hospitals merge, we don't observe actually improvements in quality. What we tend to observe is that volume goes down and staffing also goes down. And that maybe sounds intuitive to me, because if you two hospitals merge and they are providing similar services, then you can see that as a result of that, there may be some reorganization, and therefore activity and staff may be reshuffled around. So what does that imply for policy? Well, at the moment, hospital mergers are rarely blocked. Maybe that may be for good reasons. But at the moment, I think regulators are really quite struggling to assess prospectively what's going to happen to the quality when the hospitals merge. So again, at the moment, hospitals claim that the quality is going to go up. But the evidence doesn't suggest that that's the case. So that hints that we may need like a better regulatory arrangement to make sure that the regulators can prospectively assess these quality claims. Now, the last policy I want to mention is integrated care, which is often discussed in a very independent way from the competition, the provider competition policies. And the people who are interested in competition are not the same people who are interested in integrated care. So I want to try to bring this together and try to answer the question that Ewout mentioned at the beginning. Is it the case that these two are in conflict? So if you look around European countries and you read a bit about integrated care, what seems to come out, at least in my reading, is that primary care is supposed to be the lead actor in developing coordinated care and integrated care. So if that's the case, then perhaps there isn't like a big conflict between competition and integrated care, because GPs could compete for patients to provide better integrated care. So that to me shows that it is not necessarily the case that the two ideas of integrated care and competition are necessarily in conflict. You could have some scenarios where integrated care is in conflict with competition. So if you are going to integrate hospitals with primary care and everything else, so that all the hospitals and the primary care, they are all owned by the same organizations, so you have a higher level of integrations, then that will eliminate competition. But even in that case, I still wonder what's going to happen to patient choice. So you could think this very integrated system, they might still want to allow for patient choice. So again, there may be some elements of competitions that will remain even in some very integrated institutional setup. Okay, so just to conclude with some final messages. So again, if you're someone who is still hopeful that competition might work, there is we have like a good starting point, perhaps, and there is scope for further improving provider competition, and that can be related to public reporting, making sure that patients make informed choices. And so the competition really, these provider competition policies has to be interpreted as a means to an end, not an end in itself, which is how sometimes maybe politically this is interpreted, is that, you know, you want to have a competition because this is, you know, you believe in markets that they will do a good job. So provider competition really, the second point I want to make is that provider competition really needs to be integrated with other policies. So I've hinted this a bit when I was discussing integrated care. But if you're thinking about the two main policy objectives, which is improving quality and containing cost, there are many other policies that try to do that. We have auditing, monitoring, minimum quality standards. We develop payment mechanism, pay for performance. So all these different policies, they should act in a coordinated way with provider competition, so that competition is not necessarily in competition with these other policies, but they can act in a more integrated way, using both the words competitions and the integrated care in a very different way. So on that note, I just want to thank you for listening to my presentation, and also thank my co-authors, Martin Chalkley and Hugh Bell. Thanks a lot.
Thank you very much, Luigi, for these good insights, and I think they will also spur some debate and questions among our audience here. And also for that reason, if you have a question, please post them in the chat. Before we go to the next speaker, we will go to Erica, because Erica has the results of the poll, I believe. So Erica.
Thank you very much. Yes, poll results. Could you pop them on the screen for me, Lucy? Yes, 3/4 of you, of those who answered, said that yes, you think increasing competition between providers is beneficial to the health system, with a good spread of reasons why, but increasing patient choice is seen as one of the key benefits, which is interesting in and of itself. And it'll be interesting to see how this plays out with the country examples. Back to you. Yeah.
Thank you. Yeah, indeed. Very interesting results. Do we have a very favorable to competition public, or, you know, let's see. Okay, then we next go to France. Karine, the floor is yours.
So this question about Karine Vincent, and this question about provider competition will be viewed through the French healthcare system. So first of all, what we need to say before speaking about that is that we have a national healthcare insurance system covering all the population, but not covering all the healthcare. So we also have private health insurance covering something like 95% of the population. For complementary healthcare, meaning when healthcare are only partially covered, we may use this private health insurance. And for supplementary healthcare, when healthcare are not covered by the national insurance healthcare system. So we have the two. Yeah. Okay, that doesn't matter. I know, could be better. And so saying that, we need to understand that we have two systems. Even if we think about healthcare system, actually we have really two systems: primary healthcare on one side and secondary healthcare. Are they connected? Patients are free to choose their family doctor. They can easily change. And patients are free to choose their hospital. So we may have connection. We have connection because of this movement to integrated care as everywhere in US or in Europe, but still there are, we have two different kind of healthcare system. Why I emphasize on this point? This is because when we focus on primary healthcare system, doctors are mostly self-employed. They belong to the private sector. They are free to choose their location. They are free to select patients. They contract with the national health insurance system, health insurance system. They have different options. They may choose the fixed price option, or they may choose to be paid more than this fixed price, and there's different kind of savings. I don't enter in this black box. But what you need to understand is that a physician can be paid differently according to the kind of option that they want to choose. And what we should observe then, the better in quality should be the one with higher price. But actually, it's much more complicated. The main reason is the lack of providers. And it's very obvious in rural areas or poor suburban areas. So to conclude on that, what we observe is that competition means that quality when people can afford it, but also when there is enough providers to compete with each other. About the secondary healthcare system, we have to simplify. We have 3 types of hospitals: private hospitals, and in the public hospital, into them, we have university hospitals and local hospitals. We had a huge reform in 2008 with the introduction of the DRG-based payment system for all types of hospital, meaning private and public, with equivalent fixed price. So hospital compete on quality. What should we observe? For private hospital, we should observe an increase in the competition because of this reform. Actually, private hospital competed before the beginning of this reform, from the beginning. And the introduction of this reform changed things, but not so much. Why? How can we explain that? The main reason is because patients have to pay out of pocket to go there. This is why introducing the insurance was very important to understand how we can distort the model. They are small, very numerous, accessible, geographically accessible. They are almost everywhere, but you need to pay an out of pocket, and the reimbursement can be done by the private insurance and depend on your package. About local public hospitals, doing research, we observe they are small, very numerous, accessible, but badly equipped. What we can observe doing research on that is that because they are very numerous, not so much so far now, they are less and less, but however, in terms of distance, it's quite easy to go there. And doing research on that, we observe that in the poorest area, people go there, or very edge part of the population, 80 and over, go there too. And we also have university public hospital. They are very concentrated in the very density urban area. So what we can say about all this stuff is that when competition works, when we can introduce competition, we observe that quality measured as depending on how it's measured, but according to how it's contracted. But we can observe that we have quality, efficiency, performance, and but definitely we have selection that is based on clinical aspect. We also observe affordability issue, accessibility issue, based also and connected with a shortage of providers. And one of the very critical point is about non-profitable healthcare activity, because what we observe is that for a range of healthcare, we may have competition on the French territory, but for a part of the healthcare, we do not observe this competition. When I say that, I think about more complex patients than that are only cured in university hospitals. And it's also connected with the question of hospital mergers. that was introduced in France in and effective in 2017. So with the COVID pandemic, it's difficult to say something because we only have 2 years of implementations, and after that it was disturbed by the crisis, but still we may work on it to see the effect. So then thank you to everyone, and here you have some publication based on what I said today. Have a nice day. And this is a following.
Thank you very much, Karine. And I also see that people have questions for you, which we will come back to later after we hear from Mika from Finland. So Mika, floor is yours.
Thank you for this opportunity to provide some insights from Finland regarding this topic, this healthcare provider choice and competition in healthcare markets. So I decided to concentrate few topics, not go to very much into details regarding the system or institution, but I would like to anyway start a little bit what kind of competition we have in Finland regarding healthcare markets. So I think Luigi made a good start with discussing that this competition is multidimensional in healthcare markets, and so it takes several forms. And this is exactly the case also in Finland. So we can basically, if we look at the healthcare markets in Finland, we can separate 2 types of competition. There is a provider competition within the market, whether we look at the primary care or secondary care. So providers compete with each other, but there are also like competition for the market. So sometimes public sector, like state or municipalities, outsource certain social or healthcare services to private providers, and these private firms compete for those services. But there is much less like research on that topic. I think it would be important to study that as well more in the future. Anyway, if you look at this provider competition, this first part, so that can be also divided to competition among public providers. So there is a competition both in primary care and in secondary care among public providers. But then especially in primary care, private providers have become very important in the Finnish system. So we have like pure private market where people basically pay out of pocket or they have insurances that they use to get these private services. But then we have also like occupational healthcare, which is quite unique system in European scale, where private providers have important roles. So this is all the time changing this market, and these private providers are becoming much more important, I would say. Then we have also kind of situation where private providers and public providers compete with each other. Like, for example, in certain regions or municipalities, there are like health centers, some of them are public and some of them are private. So that is also possible, but not very common, I would say. So the things are changing all the time, and if we look at like what has happened during the last 20 years, so many reforms have affected the market, both like competition, but also this role of private providers have changed. And what kind of reforms I'm talking about? So I could speak many different reforms, but I have selected 2 maybe most relevant, like patient choice reforms. These are kind of reforms that are very similar to many other European countries. So Luigi explained about this research regarding UK, Norway, and many other countries. So this patient choice reforms implemented in Finland 2011 and 2014 were very similar to, for example, to the reform in Norway, but also to the reform of what happened in UK in 2006. So it's became possible for patients to choose provider, public provider. First in 2011 in like a smaller area, and then this was extended in 2014. So these two reforms are something that we have to understand much better in future, and this is something that I'm working on now. And interestingly, there was also like so these reforms are both for the primary care and secondary care. And there was a kind of pilot, a regional reform in 2007 in some part of the Finland. So that's something that we have been looking at recently. So we have a paper. Unfortunately, it's not yet in the internet, so we will publish the working paper soon. So we look at in that paper this regional reform implemented in Western Finland, which this looks at this kind of this can be seen as a pilot reform of this 2011 patient choice reform. So let me quickly explain the idea of this reform using the Finland map. So usually these patient choice reform are nationwide. So for example, in UK and Norway, they were implemented same time. But this nice thing about this reform is that there was a regional element. So it was implemented only in the gray area. So we can look at what happened in this gray area when patient could choose hospital and compare that to this other parts of Finland. So we have a kind of control or comparison group. And using this kind of setting, we have found that some similar results compared to what Luigi went through using these other countries, the evidence on other countries. So we also find that this reform affected patient choices. So patients started to choose hospitals more actively after the reform, and it also decreased waiting times, and that was one of the aim of the reform. But maybe most interesting results, which hasn't been found in earlier literature, is that it also affected competition, because this is something this previous literature basically assumes that when there is a patient choice reform, it increases competition. So we interestingly find that patients started to choose university hospital, big hospital, or this teaching hospital, much more likely after the reform. So it has a big market share already before the reform, but this market share increased much after the reform. So in some sense, it's actually could see that it decreased competition in that sense. So anyway, this is something still like ongoing research, and I think this is definitely a topic that needs to be investigated in much more detail, like in general, these competition issues in Finland. Thank you.
Thank you very much, Mika. Then I would like to invite all the other speakers to switch on their cameras, and also to ask Erica what she has been reading in the chat, which has been quite alive, I think.
Yes,
Erica,
it has
kick us off.
Yes, it's definitely been a lively chat, which is great. I'm not complaining about that. So one of the sort of areas of questions has been around hospital mergers and whether or not merging hospitals actually does increase efficiency. But also the sort of like flip side to that is about where you have a lot of quite small providers, particularly private providers, good coverage, but surely that is fragmentary in the system. And a big kamarjoba to my colleagues in Georgia who've joined us. And there's a lot of discussion about patient choice and how competition can be limited by many factors, but particularly the availability of health workers. So if you don't have enough GPs, you don't get the competition, you don't get the improved patient choice. So that was another issue that's come out. And of course, there's always the big question of how much competition policy is actually linked to more of an ideological drive, and what happens when you get a change of government. So how does that impact on competition policy? So
shall we perhaps start with the last point, a bit more talking about the process here, and so, because I was exactly having the same question. Is it really, what were actually the objectives of the reform? Was there also a political element in that? So maybe we can do a quick round, maybe start with you, Luigi. I mean, I know you've looked at more countries, but it's fine if you want to focus on one, and then we'll go to Karin and also to Mika.
Yes, thanks a lot. Yeah, well, actually, I was going to answer the questions in the way Erika mentioned them, because I think I have some ready answers there. So I think the one on the mergers, I think the evidence suggests that there is no effect on quality, but costs go down. Whether that's efficiency or not, that's a slightly different issue. So you know, if you have less volume, or if you have like few, you fire like few people, that will reduce cost. That doesn't mean that the hospital will become more efficient. So I think we know the effect on cost, but not necessarily on efficiency. So I think that's my answer to that point. I mean, the related point was also about all these small providers. If you have a lot of small providers in the regions, there could be like a good an efficiency rationale for merging them. So in that sense, whenever I think what we observe in several countries, maybe France and Germany, is that whenever small private providers want to merge, and there are many others around, this is like a no-brainer. You just want this to, because that's not going to affect choice. Patients still choose quite a bit. So that's not an issue. But I think that maybe I saw the comment from Greece that there is like maybe one more fundamental point that relates to provider competition, which is, some countries are quite stretched and they have limited resources, and they have like big access demands and backlogs. What does provider competition mean in those contexts? I mean, if you are like a provider, you're already struggling so much to try to treat this excess demand. Why would you actually want to compete to get even more? You're already struggling. So I can see that the whole, and I think this is understood in the literature, that the case for this provider competition is much weakened in countries with large excess demands. So I think that's what I would say. In terms of the ideological drive about, I think you're right that most of these policies are ideologically driven. That's how they're introduced. But I think then they evolve over time. So hopefully they still, although they have this ideological component, then when is the time to look at the details, then that's where the health policy guys get a bit more involved, and maybe they can help to fine tune the system so that actually these policies can be introduced to help the health system, rather than just remaining some vague generic ideological brand saying, okay, let's introduce market reforms in the health sector because that's going to make the health sector more efficient, because that's not going to happen. Okay, thank you.
Thanks, Luigi. Maybe let's go to Karin, if you have any inputs on what it just has been said, and also about, what were the goals of the reform in France, and was there an ideological component, and has it changed over time?
First of all, I just want to make something very clear. Public and private hospital, if you go to public or in private hospital, we will be reimbursed. You do not have, we'll be reimbursed by the public healthcare insurance. The only difference is that in private hospital, you need to pay an out-of-pocket additional payment that will be not reimbursed by this public, the national healthcare insurance system. So this is why we have this kind of fragmentation in the providers, but also fragmentation in the consumers. What I want to say by that is that in private hospital, people go there when they can pay for that. They can affordable when they can afford to pay this additional payment. Otherwise, they have to go to the public hospitals. We reduce the number of hospitals, so we may have a lot of, still have a lot of public hospitals, but less and less. And about reforms, we have this very recent reform that is hospital mergers. What is called, it doesn't matter. in 2017, and this is only for the public sector. So private hospitals cannot go into this group of hospitals. The group of hospitals are done for public sector. And about the positive impact of that is about patient pathway, because then when you go in, because this is a group of hospital, most of the time there is an university one, then patient, according to the healthcare health status, can go in a local one and then be redirected to the university hospital if needed. But what we observe so far is that payment still are per hospital and not per group of, not per network of these public hospitals. So we have this disconnection between incentives and how reform are done. So I think that is part of the issue. And the second part of the issue is a population fragmentation that is really important to understand about where we can compete. We can compete when we have enough providers, and we do not have enough provider when it's very complex. And we do not have enough provider when people are very vulnerable. Deprivation is a key variable also, because they are much more costly.
Yeah. Thank you. Mika, your thoughts?
Thanks. Maybe first about this hospital mergers. So I think there is still a point for like economic point of economic scale and learning by doing. And there are papers finding impacts, like positive impacts on quality for these mergers. But I think it's often we talk about very small providers, very small hospitals are merging or closing down. And this is something we have found also in Finland for maternity wards. So when maternity wards were closed down in the end of 80s, early 90s, so they were very small. So we actually found positive like impacts on health outcomes after that. But later, when we look at these closures or mergers, so the impacts have been very different, because now we talk about larger units, larger hospital units. So I think it's quite expected that that economies of scale stopped at some point, and but when we talk about very small units, so it's possible to find these impacts. So that maybe that's one point. The second point regarding these reforms, I think it's these reforms have usually very similar like aims. So when we had this in Finland, so we were looking at the experiences from other countries like Sweden and Norway, and so the aims were really to improve choice opportunities for patients, the quality, and then important thing was also this waiting times, because that's something we have been struggling in Finland. So to reduce these waiting times. So yeah, thanks.
Thank you. I've seen lots of activity in the chat. I don't know, Erica, if there are some last questions for a final round.
Yes,
Oh.
there are. So one of the things that hasn't really been spoken about is the challenge of information or data sharing, where you have competition, and if there are any insights into policies around that. Obviously, the influence of competition on the health workforce, whether anyone's done any research into that more specifically. And do you think performance-based payment systems increase competition and quality of healthcare? And then a massive question, which I think I might need to refer people to previous webinars that we've done, is how are we measuring quality here? So what are our metrics for that?
Indeed. We have a whole series earlier this year, 3 webinars on quality. Please have a look there as well. They're still on, on YouTube. Let's do it the same way. We start again with Luigi, if he has some thoughts on those 3 bits, namely information and data sharing versus competition. the effect on the workforce, very interesting, an important question, and perhaps performance-based if there is time. But maybe you want to focus on one or two, Luigi.
Thanks a lot. Yeah, so I think the data sharing really has to be sorted out, because if you want to have a public reporting on all these indicators, I think some countries have done this more successfully than others. I know that some countries, maybe in Germany, it's quite difficult to find quality indicators in the public domain, and maybe this can be rationalized. So in terms of how quality is measured, these are the usual indicators, in the sense that quality encompasses all sorts of different dimensions, but in practice, we are always looking at the same indicator, which is like mortality rates, risk-adjusted readmission rates, patient-reported outcomes whenever they are available, and then on the efficiency side, we look at the cost, labor productivity, health workforce, and so on. So in that sense, I don't think there is anything new that relates to competition. There was one question about pay for performance and paying for quality. I think that's where you could find some substitution and complementarities between the different policies. If you can fix the quality issue just with pay for performance, but pay for performance has its own problems, and is successful in some cases and not in others. And at the moment, the evidence for pay for performance is not very enthusiastic. So in that sense, there is scope for developing both. Maybe what they do have in common is the data. So as we try to make all this effort to collect new data and capture really both the patient experience and the clinical quality indicators, I think once we have this, then this can help to push all these different policies. Yeah, so I think I'll stop there. Thank you.
Okay, maybe Karin, do you have any insights on those 3 points? Perhaps also on the effect on the workforce, which was a question that was asked.
About workforce, if you give me 1 hour, I will be happy to answer. But in 1 or 2 minutes, it's just impossible, because we didn't really focus on that and need to present the situation. But let me answer to this workforce or healthcare workers question through the data sharing. In France, we have huge of data, and if you want to work on it, if there is a researcher and want to work on it, there is a lot massive data. We have patient health record. We have a lot of information. When you go into the hospital, we have a lot of information. That is also additional job for healthcare workers as well. And we also have information on patient health when they go and see a doctor for primary healthcare. So we can mix. Why we can do that? This is because this is like a lot of countries in Europe, this is a public healthcare system. So data belong to this system, and then it's possible to share this information. The thing is that we have to go further on this information. It's used for epidemiologists, for economists, health economists, or whatever, but it's not so enough used for patient itself. I mean, when you go for integrated healthcare, when you go to the primary healthcare, and then you need to go to the secondary one and return to the primary one, it means that providers need to use it to improve the way they can think about your the way to cure you, and that is something the system tried to improve. I will say almost nothing about quality, almost one thing, only one thing, it's about observability. When we think about how to measure quality, you need to think, how can I observe this quality, and how can I be sure, and what the cost for audit. And sometimes if you spend much more money to be sure about what you observe, it's absurd. Thank you.
Thank you, Corinne. Mika, maybe your views.
Very shortly about this workforce thing. So we don't have much results, but this is hugely important topic in Finland. So, and I think one challenge what we have here is in public healthcare, especially in public primary care. So physicians are moving more and more to work in private providers. So the shortage in public primary care is really issue. So it's not just like generally this shortage that or this access that we are struggling with, but also like that this allocation between public and private providers. So this is definitely affecting the system, and we try to solve it somehow, but no good solution yet. So let's hope that we will come up with something in coming years.
Thank you very much, Mika. So that brings us all very close to the end of this webinar. And as always, we give the final thoughts on the topic, not the final word, but the final words on the topic to our keynote speaker, Luigi. So Luigi.
Yeah, thanks a lot, Wout. Yeah, I have like three maybe final messages. One is again on patient choice. So even as we're moving towards integrated care, I suspect that patient choice will still remain there, because this is really valued. Even people who are against the competition may not be against patient choice. But if that's the case, then I think we really have to figure out the financial flows that arise as a result. So if a provider gets lots of patients, they will have to be compensated for being for treating these additional patients. So I think there is a bit of thinking to be done, and I still haven't seen in these integrated care systems how these flows are going to be set up. So I think there is a bit of a gray area. Second point I wanted to make was something that came up in the discussion about public procurement and the competition for the market rather than within the market. So we really have focused between provider competition, so within the market, but there are some interesting issues related to public procurement, tendering, and competition for the market. What worries me there are two things. One is like, how can you assure that quality is maintained if you have public procurement? How do you contract for quality in the health sector? And we wrote an opinion with the European Commission expert panel on the difficulties that arise out of that. And then I also worry with this contracting, the transition between different rounds. So if you give a monopoly to someone for a few years, how do you ensure that you move from one provider to another one in a smooth way so that the patient is not affected? So I think there are like some issues related to the competition for the market that I really haven't had the time to touch on. But I think we use a bit less the competition for the market, but though we do use it maybe for buying medicines and so on. But yeah, I think for countries that want to move in that direction, those issues need to be sorted out. And my last point is that given the pandemic, we do observe all this backlog and health workforce issues. So possibly this is the time to focus on those health workforce issues, and then maybe later think about how competition can help. I don't think competition will solve all the issues we are facing. So in that sense, I think that the effort has to be on sorting out those health workforce issues. Thanks a lot.
Thank you very much, Luigi, for some good final points here. I would like to also announce that we will have 2 more webinars next week. So not 1, but 2. One on our normal Tuesday spot at 12 o'clock, and it will be about oral health, dental health care, especially talking about coverage and provision and some reforms in that area. And on Thursday on the European Health Union, together with the European Health Forum Gastein. So I hope to see you there. And for now, thank you and see you next time. Bye.